Hello, everyone. Welcome to another episode of our podcast. The topic of our discussion today is COVID-19 and more specifically how we can improve the compliance of COVID-19 and its vaccine uptake. I'll first start off by introducing the topic and then introducing our speakers, and then we'll begin the discussion. So one of the biggest challenges for public health authorities when it comes to COVID-19 is increasing the compliance of people with prescribed public health guidelines. While countries with high rates of vaccination, such as the US, have started relaxing COVID-related restrictions, vaccination rates in South Asia continue to be quite slow. Therefore, the threat of COVID-19 is likely to linger for the foreseeable future. And in that respect, a conversation that is situated within South Asia becomes paramount to address these challenges. I will first introduce our speakers for today's discussion, who have worked on different strategies of engagement that can help tackle this crisis. First off, Ashraful Haque. He is the country director of Innovations for Poverty Action in Bangladesh. His expertise is in designing and managing rigorous field experiments. Previously, he was an assistant professor in the Department of Public Administration at the Jawaharlal University. Mr. Haque managed 22 randomized control trials. Some of those were published in peer-reviewed journals. As the country director, he advises a few government agencies, including Access to Information Programs, in designing and developing evidence-based policies and programs. Kate Vyborny is an associate director of the DevLab at Duke University. She completed her Ph.D. in economics at the University of Oxford. She is also a fellow of the Center for Economic Research in Pakistan and the Consortium for Development Policy Research in Pakistan. Shahbano Ijaz is a PhD candidate in political science at the University of California, San Diego, and specializes in political economy of developing countries. She has a MA in politics from NYU and an MSc in economics for development from Oxford University, where she was awarded the Commonwealth Scholarship. At University of California, San Diego, she serves as the graduate student liaison for the department Equity, Diversity and Inclusion Task Force, and leads the Women in Political Science group. In 2021, she was elected as the Busho Scholar at Yale University. Thank you so much, everyone, for joining us. So I'll start off the discussion by asking each of the speakers about the questions that they were exploring and in the study that they were doing and what their major results were. Ashraf, if you could start off.
Who should go first?
Ashraf, I think you can start.
Oh, okay, great. Yeah, sure. So let me give you a little bit background how we started this larger scale face mask randomized control trial. So I believe on March 8, 2020, Bangladesh had the first COVID-19 case confirmed. Like other countries, where the first response is to impose a lockdown, nationwide or like a district-wide lockdown. So we found COVID case. The whole country got panicked. And then from late March to the end of May, we had a lockdown. But the problem with countries like Bangladesh is we cannot afford it, where more than 70% people are engaged in informal economy and they earn from hand to mouth. You cannot just shut down the economy. So that time we thought, what could be a feasible thing to do in countries like Bangladesh instead of just going into lockdown. So that time everyone knows mask is so much important, and by mid-March, government initiated a universal mandate of mask using. So there is a law that says if you found without a mask in public areas, you can be fined. But nobody's wearing it. So in April and May, we collected survey data. Basically, our objective was to use to collect economic hardships due to lockdown to find out that. But then we found people are like saying they use mask a lot. For example, 90% people say they use mask. But then when we go out, we find like so many people are not wearing mask. So then we thought maybe people on the survey, they are giving you a response that you want to hear. So we fielded direct observational method. So we fielded animators who can stand on the road and see people. And by May, we found that around 50% people wear masks. And by June and July, it came down to 30 and then 15%. That time we understood making law does not make people use masks automatically. You need to do something else. So that's how we came out with this randomized control trial to understand what we need to do at minimum to convince people to wear masks. So we did pilots, like 2 different pilots in 2 different upazilas, and then we found a minimal model that we wanted to test in a large scale randomized control trial. And we tested that model in 600 unions. Union means it's like a 10, 20 villages makes a union with like 30,000 people. So we selected 600 unions around the country and randomly allocated to different treatment arms. And we actually tested 30 different treatments, like text reminders, giving incentives, giving community leaders certificates. None worked. After the RCT, we found that 4 things work. That's called free mask distribution, giving information, reinforcement means we have to remind people, and then modeling by the community leaders. So if you can do these 4 things, then you can increase mask wearing rate by three times. So from 13% to 45%, which is a big achievement. So that's the story and my research.
No, that's super interesting. Kate, would you like to go next?
Sure, absolutely. So the study that we did, and Laruch and Uzair, who are also part of the podcast today, were collaborators in this project, is based in Pakistan. And it complements the study that Ashraf and his team did, in that their project focuses on how to get citizens to wear masks. And our project focuses on, and as he just highlighted, that community leaders play an important role in influencing that decision. And our project focuses on how to convince community leaders, specifically community religious leaders, to actually get on board with that message. So we carried out the study in the context of kind of ongoing discussions and sometimes contentious discussions between the national government and high-level religious leaders in Pakistan about what kind of protocols could be implemented in mosques during the COVID period. So should mosques close? Should mosques reduce capacity of total people praying? What kind of rules could they take on board? And that had raised a lot of issues, and there was generally a number of times kind of rules had been announced that where there was no kind of agreement on them, and there was a lot of argumentation about it. Ultimately, the government and the high-level religious leaders did come to agreement on a 20-point plan, which included that everyone should be wearing masks in the mosques when they come for Friday prayer, which is a very large kind of group gathering that many people, or most people, consider kind of a mandatory and a really central part of their faith practice, and as well as other kinds of procedures like keeping the mosque clean and not doing pre-prayer washing, ablution at the mosque, but rather doing it at home before you come. So there were a lot of these kind of points that had been agreed at a high level. The problem is that they were not being followed at the community level, and there was generally kind of, I would say, low awareness and low engagement at the community level, which is of course where it really matters. And so what we wanted to see what could persuade the imams, the leaders of the mosque at the community level, to start to kind of think about implementing these procedures. And so we did a telephone-based experiment where we called and used a persuasive script that called on the imams as community leaders to think about their role as leaders and their role in helping to protect the vulnerable people in their communities against COVID. And so what we found was that turned out to be very effective in convincing imams to start asking community members to wear masks when they come to the mosques. We were very excited to see that result. We also experimented with whether or not using explicitly religious content in the messaging was necessary to achieve that result. So I think I might have imagined that relating the message explicitly to a religious justification might help to increase the effectiveness of this message, and we found there was really no difference in the results. Whether we gave a general message that really called on imams as community leaders who play an important role in their community and had them think about their sort of responsibility in their community, or whether we explicitly related it to religious scripture and examples from other prominent Muslim countries and their leadership, both were equally effective at increasing the compliance of the imams. So we were excited to see that result, and we're interested in talking more and actively talking more about how that can be applied to ongoing efforts, both to increase mask usage, other protocols for COVID, as well as vaccination uptake.
Thank you so much, Kate, for that. Shahbano, would you like to go next?
Sure. So my project was looking more at reputational spillover. So I was interested in looking at whether informing individuals about the foreign aid sources of public programs, it increases trust in those public programs. And so I was motivated by a study that I think Ashraf's team did, and Mushfiq Mubarak had this early research paper on how there should be smart lockdowns. And part of that smart lockdown strategy was that you should be giving out these cash payments to encourage people to stay at home. So kind of decreasing the opportunity cost. And so the Pakistan government rolled out the ESAS emergency cash program. And part of it was funded at least through payments that were coming in via USAID or from China. And so my objective was to see whether informing individuals that this program was funded at least partially by foreign donors would change their trust in that program. And since the objective of the program was to encourage compliance with public health orders, such as staying under lockdown or wearing masks, whether it would change their behavior in that respect. And so we basically contacted people by phone. It was a survey experiment that I conducted with Gallup Pakistan. And we informed them that, just randomly informed a subset of people that this program received funding. Either, so one was that we would inform them that either it received it from the US government or the Chinese government, and then try to see whether it would impact approval of that program or compliance with willingness to comply with public health behavior, and whether these results would vary by identity of the foreign donors. So do people trust the program more if you tell them that it's funded through help from the Chinese government, or would they trust it more if you tell them that it's funded through help from the US government? And what I find is that there is not there is no impact on the approval ratings of the program. And part of that has to do with the specific instance, the circumstance that this was COVID-19. The program actually had a very high baseline approval. And so shifting that approval any further was probably not possible. But there are effects on compliance with public health behavior. So people who hear about this program and are told that it's funded through foreign donors, they are more willing to stay under lockdown. So this was interesting to see that, you have previous research telling us that there is reputational spillover if you tell people about foreign donors, engagement in domestic government. It doesn't necessarily reduce your trust in the domestic government, but might actually improve it and might actually improve your willingness. Part of the reason theoretically comes from the idea that there is more certainty, and there's your government is getting like this third-party endorsement that they're receiving this support, and so you're willing to kind of comply with what they're asking you to do. I do want to take very briefly talk about this other survey experiment that we did in the US context, because it speaks to what Kate is talking about, where we exposed a subset of evangelical Christians to this messaging from an evangelical leader that they're being encouraged to wear masks, to see whether social norms have any impact on improvement in wearing masks. And part of this has to come with, like Kate was saying, that in the US context, evangelical Christians were amongst the group that had the least compliance with the wearing of masks. And we do find that telling them, get this messaging from their religious leaders, and the other treatment was just telling them that unlike what you might believe, there is a high rate of mask wearing, or like 75% of people, of evangelical Christians, actually wear masks. And this also improved their willingness to comply with wearing a mask in public. So, it kind of confirms what Kate did in Pakistan, that receiving these messages from like a community leader, or what Ashraf did in Bangladesh, is very helpful in increasing compliance with the wearing of masks.
No, super interesting. So I think all of you used similar mediums at some level, but also different mediums. Like Ashraf, your study was mostly, I believe the compliance was judged in person, and Kate, in your case, it was done mostly using phone survey, and Shahbano, same is the case with the Shahbano study. So I'm just wondering about how you guys chose this particular medium, and if you considered any alternative medium of contacting the respondents. So if you could talk about that.
Yeah, I'm keen to talk about that sort of from the perspective of our study. So we carried out the field work, or the data collection and the experiment for this study during a period where COVID was very active in Pakistan. And what we wanted to do was to address the possibility. So Ashraf talked earlier about the problem of sort of social desirability bias in answering questions about mask wearing. So specifically, he mentioned that, when you survey people, in some contexts, most people say they're wearing masks, but when you go out and look on the street, most people are not wearing masks. So obviously the answer, you can't tell for any one person whether their answer is true or not. But on aggregate, it's clear that there's a lot of over-reporting happening. So we were interested in trying to work out how to capture the responses of the imams in our study in such a way that we would get around that problem of over-reporting, and the treatment itself, like the persuasive script itself, might increase the over-reporting. So that would be a problem for saying anything about the impact of what we did. At the same time, physical field work was considered as risky and challenging, and we were also interested in doing covering a sample that's spread over the whole of our province, Punjab, and so it would be difficult, risky, and also costly to try to arrange field work, especially at a time like that. Ashraf's team did an enormous and very impressive kind of fieldwork exercise, but our scope was smaller. So what we did is we designed a mystery shopper approach to capturing the responses of the imams. So we piloted this a few times, and it worked very well. We were very happy with it. So what we did was we had someone from our team call each imam and ask questions as though he's considering attending the next Eid prayer. It's a huge holiday prayer, and so many people come, including people that don't usually necessarily come on a weekly basis. And that caller would ask some basic questions about the upcoming Eid prayer. For example, what time is it going to be held? Because that's usually decided just in the day or two right before it happens. And at the same time, he just casually slipped in, oh, and do I need to wear a mask? Do I need to bring my own prayer mat? Those kinds of COVID-related questions. So we were not very sure when we first started talking about doing this how well it would work, but when we piloted, it worked very well. And thanks to kind of fantastic work by the whole team. And in fact, some of the imams that we called, and we were so kind of confident in the process that they actually took the time to text or call back to our callers saying, oh, we've confirmed the time now, it's going to be tomorrow at 8 a.m. So we think that this was convincing to people that it felt like a casual kind of question that they were being asked. And so we don't think that we would have suffered so much from this kind of over-reporting. And I think the statistics also show that we don't see a situation where, they're all saying, oh, yes, yes, we all follow the rules. So we were quite excited about that method. We kind of discussed internally. Sometimes people have also asked us about, is it, since we're saying something that seems a little bit indirect or maybe even deceptive, is that a concern? But the nice thing about this is it's very, very low. It's a very, very low demand on the respondent. So our ethics board, when they reviewed it, kind of agreed that, you're asking for just a minute or two of their time. It's not, asking any kind of major investment or effort from them. It's not a sensitive information that you're asking them for, and so it's acceptable in this kind of a situation to use a script that is somewhat indirect in that sense. So I think that worked well, and I think we will consider using that approach in other studies in the future as well.
Yeah.
Yeah, I can quickly jump in about my. It wasn't very elaborate, but I think echoing some of the concerns that Kate was talking about. I didn't want to do an in-person survey at that point simply because of the COVID rates in Pakistan and the ethics involved. And while I wanted to do something akin to an audit experiment at one point, the idea was that you shouldn't, like Kate is saying, be taking away time from individuals who are sort of community leaders or extremely engaged in COVID management at that point. And so my survey was actually an add-on to a Gallup survey that Gallup was doing on a regular basis in Pakistan to kind of keep track of attitudes. And so it was just it was added on to, I think, wave 8 of their COVID attitude tracker survey. What I would have wanted to do, in an ideal world, the medium to use would be to actually do aid branding. And this is how field experiments have worked in the past, that if you go to an SAS program office, you should see different forms of branding and then see how people respond to it. But it was just, it was not possible to do that in the setting that we were doing this research in. So, yeah.
Kate, actually, I liked this mystery shopping idea. I just have one question. So the mystery shopper called the Imam, and his questions, casual questions, were related to those 20 instructions, right? So if the Imam says something that is against the instruction, then we are the treatment is not working. But if they are complying with the instruction, then they are complying, and you saw a difference between treatment and control area, right? Is that
exactly? That's our main outcome. Yeah. So the imams that were in our control group who just got a survey and didn't get this persuasion treatment, where we try to kind of convince them, the control group imams are less likely to tell. They were more likely to say, yeah, it doesn't matter whether you wear a mask or not, just come to prayer. And the ones with whom we did do the persuasion treatment were 25% more likely to say, you should wear a mask when you come to prayers, please do.
Fantastic. No, good, a very good idea. The methodological innovation. And for us, so the first challenge was we got evidence, really good evidence that survey would not work for our case too, since our main goal was to measure mask wearing rate and COVID-19 infection both. So to objectively measure COVID-19 infection, we need to collect blood sample, right? Otherwise, we cannot do antibody testing. So we have to do field work, and then if we want to objectively measure mask wearing, then we also have to observe people. So that's why we needed to do the field work. And as Shahbano said, there was ethical issues involved. So we actually had to develop a very strict research protocol. And we had Stanford Medical Schools involved in developing the protocol. And for example, one protocol was, when you enter into the household and speak with someone, you have to request the person if he is comfortable to interview in the yard, which is an open place, not inside the house. And then second, we offered them mask. Okay, you have to wear a mask to speak with me. And our animators always have to wear mask, gloves, and also hand sanitizer. They also offer hand sanitizers to the respondents as well. So we try to minimize physical interaction as much as possible. For example, our baseline data collection and mass distribution of information was like 10 to 12 minutes for the treatment group. And then that's the only one time we interacted with the household. Other than that, and also we physically interacted with the community leaders and imams, but imams are physically interacting with the Muslims anyway, right? They people who are coming to pray, they're interacting with them. So interacting with them is not something that we are giving some extra risk to them. Also, community leaders, they are mostly like social leaders, political leaders. They are anyway outside. They are roaming. They are doing their work. So we just try to engage them in the mask campaign. So ethically, it was not hard to justify one extra interaction with the imam and community leaders, but with the household, it was difficult for us, and we had to ensure that we are minimizing risk as much as possible. And to verify that, we had one important measure. So all the enumerators that we hired, in the morning before they go out for the work, they had to submit a survey digitally, and it has like 4 symptom questions. Are you feeling well? Do you have fever? Do you have sore throat? Do you have cough? So we had like 4 symptom questions, and we programmed it in a way so that if someone answered these 4 questions in certain pattern, and if this person is risky, then the survey will tell this person not to go out. And we had an insurance plan. For example, if someone cannot work for that day, they will be paid half of their salary for that day. So we wanted to minimize incentive to hide actual or real response. The second thing is, whoever said they are risky, we tested them for COVID-19. Good thing is, and like if we found like many of our enumerators have COVID-19, then we could have been transferring the disease to the community, right? Because we are working in the community. The good thing is that we had like 50 to 60 risky cases, but only 2 persons had COVID positive, and they didn't have to hospitalize. So we got lucky because of this good protocol that we developed. But we had like 600 people working in this randomized control trial. So compared to the scale, the infection rate was really low, and that gave us the confidence that perhaps our physical field work didn't contribute significant risk to the communities.
Yeah. Thank you so much, everyone, for talking about your projects. And I think one of the things that all of the projects converge on is the fact that legal sanctions or a top-down approach where the government mandates, for example, compulsory vaccination or compulsory mask wearing is not very effective. There is a need for other kind of strategies like community engagement or some engagement with local leaders. And I think I want to talk about this in the context of the vaccination drive, because recently, for example, in Pakistan, the Punjab government has announced that they're going to block SIMs of everyone who is not vaccinated. SIM government has announced that they will block salaries of people who are not vaccinated. So in light of the projects that you guys have worked on, in light of your understanding, how would you comment on such measures, and do you think that they could potentially play some role in increasing the vaccine uptake?
So I can go first, I guess. One of the things I want to talk about is that so in the context of my initial research on the one I talked about first about foreign aid and its reputational spillover, One of the a future project that I'm working on currently is trying to see whether branding vaccines in a similar way about, you know, where are they being manufactured and what has their effect been in certain countries, does that increase trust in the efficacy of vaccines, and does that actually compel people to take vaccines? And I think that increasing that kind of trust is key. And again, we are also looking to extend our project on evangelical Christians in the US to see to test something similar, whether this kind of encouragement coming from religious and community leaders actually increases the chances that people are going to take the vaccine. And I think if you look in the context of the US, instead of, and you know, there might be, I'm not saying that this is the right way to go about it, but the way that the US government and some state governments have been taking this up is by offering things like, you know, lottery tickets, or I think someone was awarded like $1 million to go and take a vaccine or something like this. So I think it's more of a carrot strategy rather than a stick strategy. And I don't know which one would work better. But I think that if you're not going to the root of why people are not taking vaccines, so I believe that a Gallup survey showed that in the case of Pakistan, a lot of people have concerns with side effects. So if you're not actually going and addressing that root and trying to increase the trust, then just mandating it is not going to create compliance, particularly in contexts where we know that evasion from the law is possible, is frequent. And, you know, so yeah, that's what I wanted to say.
Yeah, so what I want to add with Shahbano that like during like this kind of large scale like pandemic situation, many of our common sense or previous evidence don't work. For example, in earlier literature, we found that once someone promised or commit to something, usually making commitment like drives better behavior. For example, if you commit that you will save money for your children education, then most likely you will do it because you made a commitment. So we thought in our randomized control trial, we thought if one treatment arm, if we ask our village people to make a commitment, and we also gave in the commitment, we also gave the religious flavor that for a good Muslim, it is important that you have to keep your promises. So in that treatment arm, we told them, are you promising to wear mask when you will be outside? So many of the households promised, but at the end we found no, like that didn't have any extra impact. So many of then text reminder didn't work. Also, we had another good, like we thought this will work, but it didn't work at the end. So we had community leaders, and we told them if they can increase their mask wearing rate 75% from the baseline, then they will get a certificate from the government. And we actually showed them a demo certificate, how it may look like. It didn't work, like it didn't produce like any extra impact. So during a pandemic, and as Kate said, right, the religious messaging didn't work better than general messaging, secular messaging. So during pandemic, many things that usually work don't work. So we need to go to the bottom, as Shahbano said, and understand why something is different in a pandemic situation and how should address that very weird kind of situation.
I guess one thing I'd like to add here is that there's been sort of an interesting evolution of the policy about this in Pakistan from an initial situation where people had to, and obviously a lot of this has been driven by evolution in the amount of supply relative to the demand. But at the beginning, you know, there was a lot of rationing which had to be done, and it was rationed, as in most other countries, by age band. Then the government has kind of progressively lowered the age band so that now all adults are able to go and get vaccinated in Pakistan. We're lucky in that respect relative to many other countries where the supply is shorter. But it's still, while there's a lot of public messaging about encouraging people to go and get vaccinated and instructing them how to do it, and the government has put a lot of effort into setting up a hotline, which I understand is working very well, the 1166 hotline, which people can call or message in order to get information and find out where they need to go. All of that is very commendable, but it's still really at the initiative of the citizen to go and arrange their own vaccination. Now they have increased the access a lot and that's, my understanding is that there's a lot of new vaccination centers opening progressively. And I would imagine that I don't know if anybody's looked at the data for that, perhaps others on the call could speak to that, but increasing the access may make a big difference as well. So you could imagine sort of divided, there's a spectrum of how much people are interested in getting the vaccine, right? So we're thinking a lot about, there's people on one side of the spectrum who, the moment they had the opportunity, went in and got the vaccine or waited in line for many hours to get it, or people who were just ready to go as soon as it came available. There are people on the complete other end who are very skeptical, very concerned. You know, they might have heard some misinformation that rumors, bad rumors about the vaccine, or generally not trust the health system, not trust the government. But there's also there's like a whole spectrum in between, and a huge group in the middle who probably are not going to take the initiative to go out and get it, but if you came and offered it to them, would be ready to go ahead. And that people can, of course, move on that spectrum as they learn more and their beliefs update over time. So I think it's interesting to kind of contrast this vaccination. This vaccination effort has had to mobilize very, very quickly on a very large scale, and it's been very impressive how quickly that's happened in many ways. But it's still very different from the citizen's perspective to have to go to take the initiative, find out where to go, arrange your transport, go there, and find out what to do and go through with it, as compared to, for example, the childhood vaccinations like polio, which are delivered door to door by healthcare workers. So it's very possible that further increasing access and further increasing outreach would actually shift the needle a lot more than the more heavy-handed approaches that are being discussed. I don't know, and I think it seems very possible that those approaches will make a big difference. Like the SIM blocking, I guess it's just an ethical question of whether that's too strong of an approach or not. And I think you could debate that either way. But it seems like it actually surprised me when that announcement was made a bit, because it seems as though there are probably a lot of intermediate steps that could make it easier and reach a lot more of those folks in the middle who are kind of not very motivated one way or the other, but would go ahead if you made it really easy for them. There could be more things that we could do to reach them before taking it all the way to a mandate. But it'll be interesting to see how that evolves and also look at the data as it comes in as well.
Yeah, I just want to add one thing with Kate is sometimes, like, if you make things very mandatory or legal or hard, you take hard stand, people will comply it, but they will also find out way to cheating, right? For example, in Bangladesh, there is like this law for wearing mask in the public places. So people has a mask in the pocket, and when they see a policeman, they wear it. And when a policeman goes away, they take it out. So during vaccine, they can do the same, right? So they will pay the person who is giving certificates. They will take a certificate, but will not take the vaccine. So people is very clever. So I don't think like harsh measures may work in this case. Incentives or other things, like why people don't want to do it, finding out that will help to design the best policy.
I actually want to thank Kate, because you just framed my dissertation for me. So my dissertation work is on last mile access. So I completely agree. I think it has been kind of thrust into relief. It's been easier for me to convince a lot of, grant agencies now when I frame it as, do you see the access issue in COVID-19 vaccinations? And I think the way I see it is putting even less pressure on the citizen. Like you're saying, it's citizen motivation. I think even where citizens are motivated, but in contexts like Pakistan, where informational, where you may have, I think, again, agreeing with Kate, I think the government has done a great job at, communicating this information very efficiently. But there are still pockets where that information flow might not be going. And it's just a case of, being unable to overcome those bureaucratic hurdles and requiring that middleman presence to actually receive that vaccine. So you may have the program operational, but people just don't know how to go out and access it just because of literacy requirements or informational hurdles, bureaucratic hurdles. So I think that, focusing on this kind of engaging local stakeholders in smoothing last mile access to vaccinations is extremely important. And I mean, my dissertation looks at whether this is going to result in politicians providing broad-based access or reaching out to their core supporters first. But I hope that in the case of the COVID-19 vaccinations, it's probably going to be more broad-based support and trying to reach as many people as possible. So I concur with her that, smoothing last mile access is extremely important, and making sure that you're taking that point of access closer and closer to the citizen.
Great. So building on that, if the government is to engage with more community leaders or more religious leaders to improve not only the compliance to COVID protocols, but also to improve the vaccine uptake, are there any lessons that you learned from your research, particularly any sort of challenges or resistance that you face with the local communities that you think might be helpful for the government in reaching out to such pockets and improving access to the vaccine and improving compliance to COVID protocols?
So we had one learning. So in many cases, like in many villages, we found like the leaders, like political leaders or social leaders, they know mask wearing is a mandate. So when we speak with them, they always speak positively, and they say they will help us, but actually they don't. Like many of them, not like actually many help, but like a few of them didn't help, and they actually don't believe in mask, but they don't say it publicly because it's their leaders and they have to comply to the law, right? So they don't help, and they say to the people, "Oh no, they are doing their work. Just let them do their work, but don't believe in it." So if leaders who you follow, they don't believe in the law or in the intervention, then they will tell their followers not to do it. And that's the biggest barrier. So I think for vaccination or any other COVID things, the first thing that the government should do is to convince the leaders. Like they need to give the leaders believe that this is something that is not bad, that is good. And if we can't convince them, then they will always spread rumors, gossips, bad information.
I actually want to take this opportunity to kind of tie the research together that we have talked about. And I think that in Ashraf's research, I think we find that messaging from community leaders matters, but what matters, I think, most is receiving this kind of, encouragement or if I remember correctly, people want to evade getting into awkward conversations about wearing masks. So getting this kind of societal treatment that, it's a social norm, you should be wearing a mask, that really matters. And I think in Kate's research, telling imams that this is important encourages them to message that it is important for people to wear masks, but we don't really know whether people end up complying and wearing masks. And in our research with the evangelical Christians in the US, we find that the norms treatment is stronger. So telling people that, others in your in-group, other people that you identify with or that who are like you are doing this, actually encourages them to engage in similar behavior. So I think one of the things that would really help with vaccination drives, we have celebrity messaging and we have all of that going on, but I think there's still this idea that celebrities are on the other side or they're different people. And so kind of getting some kind of norms and encouragement from within your own in-group. So, neighbor associations, like, for one thing that I was thinking about in the case of my mother, for example, is, you have all of these ladies engaging in roskas or committees, and, they have these dinners. And so they're thinking, oh, when can we restart our committee dinners? And, I was like, you should let everyone know that once you're all vaccinated, we can get together and eat indoors again. And so this kind of community level or, very sort of coming from your very own in-group and saying, oh, we need to do this now, because otherwise we won't get access to our community, to our committee dinner that happens every month, which we're really interested in. I think this kind of like innovative way of ensuring that, you know, norms are being spread at all levels, the universities, your peers, your friends telling you, you need to get this done because I got this done and it's important for us to come and meet together again, would really be helpful and would work. And I mean, that's how I've been reading the set of, you know, research that we're doing in South Asia. Yeah.
Sorry, my internet was slightly unstable. I think we're almost out of time. I think one last question that I'd like to ask would be that if you found anything unexpected during your research, if you found any insight that was a complete surprise or anything like that, if you'd like to share that, that would be great.
I want to share one unexpected result that we found. And so all our treatment was about mask wearing. We never spread any, and this is purposeful, we never spread any information on hand washing. We never spread any information on physical distancing. Because if we did all these things, then we could not clearly see from which message mask wearing is coming out. But what we learned, so during our observational data collection, we measured both mask wearing as well as physical distancing. And when we designed the research, we had this hypothesis that people often involve in compensatory behavior. So they do something good and then compensate that by doing something bad. So we thought if we convince people to wear masks, then they will come out and will interact in very close proximity. But that didn't happen. Actually, it happened the opposite. We found our treatment increased physical distancing by 6 percentage points, and which is statistically significant. So that was like a good, unexpected result. And yeah, so we were like really excited about it because we wanted to do something, but then we had a positive spillover in another thing.
I think one unexpected or like sort of result that kind of goes against what I saw in the previous literature is when I was doing these in my foreign aid research, when I was comparing the effects of donors, I didn't see any backlash effect against the US, which we've seen in previous research, that people will try to, you know, there's not a lot of trust in the US and Pakistan. So if you tell them about, oh, this money is coming from the US, they will actually pay. I think in Saad Gulzar's research, they will pay to preserve their anti-American identity. But there was no backlash effect in my research. And I think part of it, again, has to do with the circumstance, right? So during a situation like COVID-19, if you're getting money, and you know it's an emergency cash program, you're getting that stimulus payment, you're going to take it and you're going to approve of it irrespective of where it's coming from. So, you know, slightly unexpected in my research.
So I want to share one interesting thing, just to tell you the challenge of doing the field work. So we had to collect blood samples for serosurveillance. So there was a rumor spread out in few villages and few urban areas that some people will come and they are connected to IS, they are terrorists, and they will by talking to you about collecting blood samples for COVID-19, they will actually push COVID-19 into your blood. Okay, so, and like few of our blood collectors got, like they attacked them and they kept them on hostage until we go there and police called them and told them to release them. That was like such an unexpected situation and like very scary for our animators.
Yeah, it's understandable why people feel, you know, suspicious about, and I really kudos to you and your team for pulling off such a large scale field study in the middle of all of this, including sample collection, like but biological sample collection, because it seems like a huge challenge to, win people's trust, given how difficult of a situation everybody's in. So very impressed by that. I think from our side, the only thing that I didn't already talk about that I thought is kind of interesting is the fact that we were interested in in the possible mechanisms for the effect that I talked about we found in terms of the change in the Imam's recommendations. And we wanted to know how much of that change could be because we're informing people about COVID versus other things. And so the way that we test, one way of testing for this is to compare how effective the treatment is, the call to persuade imams to follow these new protocols, including masking, to compare how effective that is for imams who already knew about how COVID gets passed along, like who already knew the basic information, versus for those who didn't know at the beginning of the study. And what we found, so if what we were doing was basically improving their information about COVID, what we should find is that it would be more effective for people who didn't know at the beginning. But actually what we found was the opposite. The treatment was really effective for imams who already had the basic understanding of COVID. They knew that it's something that a person can be sick and you can't necessarily tell it by looking at them. They knew that you can spread it without touching the person, just by standing nearby and coughing or sneezing. And so I think there's kind of two implications of that. One is that, there's some basic groundwork that's was already accomplished even before we started doing this, which was it's now in 2020. Most people, actually, the majority of the imams in the study already had that information, but they needed an extra kind of convincing to persuade them to act on it. And I think that point really echoes some of what was discussed earlier and when we were discussing possible approaches to vaccination, which is that there's some basic groundwork that has to happen there, but maybe you have to think about what are people's motivations in order to convince them to take extra steps. In this case, it was the imams to kind of play that leadership role. In the other case, it's convincing people to take the extra step of going out and getting vaccinated, or kind of taking some action in that regard. The other aspect of it is, what about the people who didn't know about the basics of COVID? Why is it that there's still I think we had about, if I remember correctly, about a quarter of the sample who did still have misinformed information at the beginning, and they were not responsive to what we said, even though we gave information that should have corrected that belief. It wasn't effective with them, and some of that may be because they're just less trusting of information that's communicated, like public health information that's communicated in general. So again, I guess it comes back to this issue of, you might need to take different strategies for people who are at different places along that spectrum. And so a lot of the imams in our study were somewhere kind of in the middle ground, like they knew the basics, they weren't really doing anything much about it, or they weren't taking a very active role. But then when we encourage them to think about it in context of what matters to them, which is their leadership role, what they value probably a lot about themselves, which is, I'm an important person in my community. People respect me. I have a lot of responsibility. People look to me for guidance. Connecting it with that really kind of pushed them into the more active camp. People somewhere else on the spectrum who are more skeptical to begin with, they might need some other kind of intervention, because what we did wasn't very effective for that group.
Thank you so much, everyone. So I think we're out of time. Any concluding thoughts? Or should we wrap up?
Thank you so much for kind of preparing this and doing all the work to organize it. And thanks again to Ashraf and Shahbano for fantastic research and for taking the time to share it.
Thank you, Kate. Thank you, Shahbano and Lalaruk. This is like really interesting discussion.
Yeah, thank you. Thank you for bringing us together on this platform and allowing us to talk about this very important research.
Thank you so much. That was a great conversation. Does anyone else want to add anything, or should we conclude?